without ado, I will turn this over to Dr. Noecker, and thank you, sir, for doing this.
All right. Thank you, Joe. Let me see. So, so to share my background a little bit, you know, I've been using some version of Molteno, you know, the original Moltenos back, you know, 25 years or so. But, you know, with the remodeling, you know, the newer models, probably about, you know, a 10-year history. So I'll share my experience with the Molteno3 specifically is what we use now. You know, I'm a tertiary glaucoma guy, referral glaucoma practice. I do a lot of cataract surgery as well. And, you know, certainly the world of glaucoma, we're getting more and more therapies, but, you know, this is one of the standby tools that I still do, you know, practice almost every week, you know, for these tough patients when you really need to solve the problem. This is the Molteno3 is where we go. So we'll go through. So what we'll do is we'll go through some prepared comments, some kind of background material, look at just relatively efficacy and kind of the rationale for using the Molteno3 versus other tubes, or why use tubes at all, really. Because I think they definitely still have a place in our therapy and probably never will go away. And I think will increasingly grow, actually. And number two, then we'll go through like my surgical technique, and then we can kind of open it up and share notes. Okay, sound good? So I want to share my screen. Okay, we good? Can you see my screen, Joe?
Perfect.
Yes, I can.
All right, here we go. So Molteno3, as we know, is you know, a glaucoma drainage device. You know, the other ones in this, they're commonly used in the, you know, in the U.S. in this area are the Barvelt and the Ahmed. I think, you know, and the way I put it in my practice, and I certainly have used all three and other ones on the market, but you know, in current practice, I think it's kind of like Molteno3 is kind of like Goldilocks. It's a happy medium. It's smaller than the Barvelt. I think it's easier to manipulate. I think it's a less traumatic surgery. But I think in terms of IOP lowering efficacy, it's better than the Ahmed that way. So we'll talk about kind of the differences and certainly the different tube techniques. But I think a lot of it comes down to the material and design is what makes the Molteno a little bit different. So it's the nice thing about Molteno is it fits in between the rectus muscles. So unlike a Barvelt where you really have to be pretty sure you're tucking the wings under the rectus muscles to avoid diplopia or just implant migration, the Molteno3 really sits in a very similar space, just like the Ahmed. And I don't touch the extraocular muscles during implantation, and I think that's an advantage not to have to do that. You know, as much as what we do with a similar, like with an Ahmed technique in terms of implantation. So there's a little, and it has a nice low profile. Part of the problem too is with an Ahmed, especially in smaller eyes, it's actually pretty long. So the Barvelt's wide, Ahmed's long, and once again the Molteno's in between. And I think it's kind of a pretty ideal size of implant to put back in that space. The other thing is the material. I think it's really an optimal material to put in the human body compared to the silicone that we see with the Barvelt and the Ahmed. They tend to be the polypropylene of the Ahmed, which I think are kind of less biofavorable materials. And we'll show a slide about cell adhesion and may explain why we get, you know, more fibrosis with the other devices, I think. The idea is that we have delayed drainage. So with this device, we don't use a valve. And the idea is to tie it off and stop flow back to the plates. We'll talk about in technique-wise tricks you can do to get some kind of early flow so that we can kind of tamp the IOP. But really the action time is about a month out of surgery when there's full flow back to the plate. And that delayed flow is probably important. As we know, the aqueous of glaucoma eyes is really full of inflammatory mediators, which enhance scarring and it secondarily leads to decreased long-term performance of some of these glaucoma drainage devices. So we'll talk about how to do it, but you tie off the tube and let it sit. Typically what I use is venting slits to get some early flow. And once again, it keeps that kind of pro-inflammatory aqueous back away from the main body of the plate. So when it does open, we don't get a big old BLEB. We tend to avoid the high pressure phase that we may see with an Ahmed. And I think in turn that leads to a more favorable long-term IOP lowering. Other thing is the plate design is that when we look at the Molteno, there's a little area, kind of the primary filtration part, which kind of stages the flow. So it kind of traps the aqueous there and keeps it away from the main plate, once again, leading to a more kind of controlled exposure, I guess I would put it, of the aqueous to the plate. And once again, you tend to get less of that thick encapsulation that happens, especially we see with the Ahmed, but it certainly can happen with any of these devices. But I think the Molteno design and the material helps to minimize that kind of, getting a big old dome BLEB at a really high pressure, even though there's aqueous flow. So when we look at the relative sizes, it comes in 3 sizes. The pediatric size is relatively small and very similar to the original design. The Molteno 3 SS is probably the easiest one to do, and that's the one I start with. It's 185 square millimeters. The SL is 245. So kind of approaching the size in terms of surface area of the barbell. And some of the thinking around, IOP lowering is related to plate size. That's in the older literature. I think that with the Molteno, despite not having quite as big a surface area, I tend to get pretty good IOP lowering, often in the mid-teens. And I think, once again, it has to do with the design and the material. I think the body just tolerates it much better because it's a smooth, more biocompatible material, which in turn you tend to get less fibrosis. And I'll show some tricks of what I do too to minimize fibrosis as well. So if you had to choose, I would choose the 185. It's a pediatric eye, certainly go with the smaller one to start with, and then maybe bump it up to the 185 if you're someone who is inclined to do 2 tubes. The 285, I think we reserve for the tougher cases, but I usually can get the job done with the 185. So when we look at the literature in terms of efficacy, it's very favorable. The the Molteno 3 performs as well as the other glaucoma drainage devices, especially even when used as a primary surgical intervention. Classically, we reserve tubes for kind of after failures of other surgical procedures, and that's appropriate. But I think there's certainly many cases where it makes sense to use a tube first thing and just get the job done, because of the high rate of failure or postoperative care that may be involved in, say, doing a trabeculectomy, or a patient with uveitis you're going to be battling the whole time, or a patient with neovascular glaucoma where it's going to be bloody. And doing a tube in those patients, it often would be the optimal first-line therapy. When you look at Molteno versus trabeculectomy, once again, it depends. In this study, they compared the 2 therapies, and certainly it always looks at how you do the data. But when you think about it, trabeculectomy, when you look at the trabeculectomy data, certainly on average, you can get good IOP lowering with a trabeculectomy, and it's the quote unquote gold standard. When you look at, on the other hand, when you look at trabeculectomy data, there tends to be big standard deviations associated with that. So even though the mean IOP lowering may be good, that means you have some people who have really low eye pressures, like single digit, like not so good for seeing eye pressures. And then also you have the failure cases where it works for a while and then shuts down. So I think you get a more, even if you might not get as low IOPs with a tube, I mean, you kind of accept that. And I think in some ways that's good, that you're not going to end up with a low single digit pressure forever. And with the increased risk of, hypotony, maculopathy, et cetera. And then the complications associated with the BLEB, you can get good IOP lowering with a Molteno 3 compared to a trabeculectomy. When you look at the efficacy versus a barbell, it tends to be a little, when you look at averages, it tends to be a little bit lower. But in my hands, I find that the way I do it, I end up with very similar eye pressures to the barbell. So, when you look, once again, looking at what population you're doing, in this particular study, the barbells end up at 17, Molteno 3 at 16.6. I find very similar IOP. And I think even though this is a smaller device, once again, I think it's a material advantage, which we'll talk about in a second. This kind of says the same story. The percent IOP reduction was higher in the barbell group versus the Molteno. Mean IOP reduction was similar, but really not that far apart. When you look at IOP reduction compared to the Molteno 3 in the long term at 2-year data, compared to the Ahmed, we see this study showed that about 1.5 millimeters on average compared to the Ahmed. And my experience is consistent with that. I usually get a few points lower with the Molteno 3 versus and Ahmed. And looking at Ahmed versus Barvelt, which is, you know, a well-published study. This study showed Barvelt had a couple millimeter advantage over Ahmed. And I think the literature is very consistent on showing that the Barvelt lowers IOP better than Ahmed. So why is this? I think, you know, without a doubt, glaucoma eyes have a lot of inflammatory mediators in the aqueous. And once again, once the flow starts going, and we see it no matter what device we may use to shunt aqueous. You know, even with the Zen, you'll see this where the conjunctiva gets pretty hot once you start filtering that pro-inflammatory aqueous into the subconjunctival space. So once again, part of the theory here, and I think explains why we have, you know, long-term good IOP lowering and less kind of, you know, high domed BLEBs with the Molteno3 versus another procedure where we may immediately have aqueous shunting into that suprascleral space. It's the presence of inflammatory mediators. And last, and I think for me, so I'm like a material science like nerd. You know, I think the material that's used in the Ahmed really, number one, it's very highly polished. You can see it kind of visibly when you just look at it with your naked eye. It tends to be much shinier, you know, versus the white barium impregnated silicon of the Barvelt or the kind of hazy polypropylene of the Ahmed. It tends to be a very smooth surface. And, you know, it's not that hard to see that the smoother the surface is, the less easy it is for fibroblasts and other inflammatory cells to adhere to the surface. And I think that explains and we've seen this in the old days with IOLs, and, you know, they got better over time and turned to be more smooth and polished. But I think you get less of an inflammatory response, just the kind of less rough material that you're implanting is. So that's the first part, just to get us all on the same page and kind of give a background of the Molteno3. So now what I'll do is I'll go through my surgery videos, and then I think, like, when we open this for questions, if we want, we can go back and talk about certain fine points. This is a technique for me that's evolved took like a 10-year period. I really haven't changed that much in probably the last 5 or 10 years. I've been doing it this way for a long time. So I have 10, 15-year-old follow-up on some of these patients and understand exactly what's going on. So, and I think, you know, you can do variations of the same thing with any of the devices, but I think this is kind of best for the Molteno3. I think the way we do this is best. And then once again, the nice thing about the Molteno3 is we can kind of work around. I prefer to put it in the superior temporal quadrant, just for the most space. There's no, you know, oblique muscles in that area. I think number 1 is superior temporal, number 2 is inferior nasal, and then 3, 4 is superior nasal, and then inferior temporal. Those are kind of the preferred clock hours. So once again, it's not like giant, like a Barvelt. You can kind of work around the quadrants, and I think it usually, you know, 95% of the time we can get into the superior temporal quadrant. The one danger is I think you have to stay away from areas of a lot of mitomycin exposure. You don't have to stay away from them. You have to be aware that you're going to be a higher risk of hypotony. I think you need to do a few maneuvers to make sure you limit that, because, you know, these mitomycin exposed areas may never heal up perfectly. So we have to think about that when it comes to, especially to surgical closure and what materials we're going to use to kind of help with the post-operative healing. So typically make a superior temporal incision, make space, make a pocket in that superior temporal quadrant, and do blunt dissection. So this usually takes, you know, about a minute into the case. So here's a video doing that. This incision is made over the lateral rectus here. Then we're going to just kind of move up around into the superior, basically up toward where the superior rectus is, and open it, and then just relax it back. You know, certainly all conjunctiva is different. Some is stretchier than others. I don't do a lot of cutting because you're just never exactly sure where the insertion of muscle is. So, but I just do any obvious and make sure I always cut up in the air to avoid the muscles. And then usually just like to do a blunt dissection with sternotomy scissors to make space. And I think making space is a big key, so that the device is not resting on the muscles. This is a nice, easy pocket. We'll just be able to slide it back in, so it makes implantation easy. But also, I find that the plate, you know, all these devices has positioning holes that you can suture. That's fine. I've gotten away from that. And I find if you make space, just the natural kind of domed contour of this device will find its natural kind of where it wants to be, its happy place, I guess is the way to put it. The thing you have to do either right before or after you implant the tube is you need to ligate it. I tend to favor using a 7 or 8.0 Vicryl. That times out for, that will relax or lose tensile strength within about 3 or 4 weeks. After doing that, it's best probably to put right in front of the plate, but you also can do it more anteriorly. Just grab the device with a big forceps and we'll shove it back into space. So here's the device going back in. I just simply lift up the conjunctiva and then just slide it back here. I think the biggest obstacle in this case, honestly, is probably the lid speculum. So once it gets back to the equator, and the idea is you really want kind of the best position, I think, is that it gets behind the equator of the eye, and those natural forces will stop the device from migrating forward. There's kind of a natural barrier, kind of a tight spot there once you have the anterior lip behind the equator. And then you trim the tube accordingly, so you leave a couple millimeters in the anterior chamber. But that first thing is just get it back in that space. And usually once you get through that tight spot, like which is where the insertion of the rectus muscles are, it tends to pop back. And if you want, you can move it side to side. I don't think that's necessary in most cases. It usually will just find its best place. Here's another example of insertion. Once again, just lifting up the conjunctiva, kind of just nudging it back there to get past the equator. And the type of forceps I use are really anything 0.5s. This is a tying forceps, which is a little wimpy, I guess. But it's just about back there now, and it'll stay that back there automatically. So next we wanted to, so I don't, once again, you can see in a prior video, there's positioning holes on these devices. And certainly the classic teaching is to use those holes because they're there. The original Molteno had 4 positioning holes, 1, 2, 3, 4 in the back. And we kind of realized that didn't need the back ones anymore. My position is you don't really need the front ones anymore. If you get it back behind the equator, number one, it's less, I don't say it's less work, but it is less work. I think it's less risk because once you get back 8 millimeters, you're getting back to where the aura is and you worry about the retina. And why I started doing it is when I was teaching residents when I was at the University of Pittsburgh at the VA, of course, I watched one of the residents put the needle straight through into the retina. And after that, we decided to say, okay, let's figure out a better way to do this because the risk is not worth it. You're trying to lower pressure, but then you don't want to risk somebody getting a retinal attachment. So we found that, by eliminating suturing, that the natural design of the Molteno3 kind of lends itself for staying in position, and we never lost anything. So I've been not suturing plates for probably over 15 years now, and it's never really been a problem or something we miss. So something to think about. I'm not certainly going to criticize anyone for doing it, but I think it's always good to question why we do what we do. So trim the tube. The second thing is the tube is silicon, and silicon, the endothelial cells, the hydrostatic forces, endothelial cells tend to get attracted to the silicon. And so I like to put these in the sulcus. So even if the patient has to be pseudophakic, so sometimes I intentionally make them pseudophakic before this. I often combine this with cataract surgery in any older patient. If they're 20 years old, you probably don't want to do that. But it just to be able to put the tube in the sulcus, and it makes a lot of space in the eye. And we know that with glaucoma surgery in phakic patients, they often get cataracts as a result of either the steroid therapy or just a simple intervention. So I like to put these in the sulcus because my position is silicon tubes are at risk if they're in the anterior chamber. They need to be like laying on the iris. Like you have to keep them away from the cornea because all it takes is a simple rub of the eye to put the tube in contact with the corneal endothelium. And the corneal endothelium like the tube better than their basement membrane. So you'll start losing them over time. So I like to have viscoelastic in the eye. So I make a paracentesis. I inflate the sulcus, just put I used to use Helon GV. Now I use regular Helon. It's okay. But the idea is to lift up the iris, push back the IOL, and go into that space. So if you bevel, if it's in the anterior chamber, you need to bevel the long bevel against the iris. And if it's the posterior chamber, i.e. sulcus, the long side of the bevel needs to be superior, once again, against the iris, and kind of the open side of the bevel toward the IOL or the lens. I like to put it on a viscoelastic syringe. So whatever viscoelastic we're using, I put the needle on that 23 gauge needle. This is true for all tubes. Use 23 gauge needle, I think, is best. And I like to do that. So I'll insert the needle. Once I know I'm in the space, I can see I'm in that space. I'll inflate the sulcus with viscoelastic, or if it's the anterior chamber, I'll inflate it just to push the iris off, most often the iris, but also the IOL. Out of the way, and just enlarge that space. So number one, it's easier to hit the target when we're putting the tube in place. And it's also just for safety to keep tissue from being traumatized, like, i.e. sticking the needle in the iris and making it bleed. The entry site, I think optimal is about 2 millimeters or so. It certainly does matter which way you angle it, but I think the best location is kind of parallel to the iris, parallel to the IOL, kind of straight in. That tends to be about a 2 millimeter location. So here's the plate. It's been placed. You can see there, and now we're just going to bevel posteriorly. I like to leave a couple if it's posterior, I like to leave it the tube a couple millimeters in the eye. If it's anterior, I like to keep it between 1 and 2. So more short when it's anterior. Once again, just to keep it away from the cornea. It's less tube to kind of encounter the cornea. But I think it's better when it's posterior to keep it visible and kind of stop it from going around the zonules or anything like that. So here you can see placement. I think it's always good to make the needle track parallel to the natural. You can see it's running, this is running parallel to the tube that's sitting there ready. I'm putting it into the sulcus. You can see it's the bevel on top of the IOL, and on the way out, it was a little bit hard to see there in that video, but I injected viscoelastic. And I just take the tube. We have a nice needle track, and you'll see it emerge, hopefully. Here in front of the IOL, there's a little tip coming out right there. And so that's a nicely placed tube. And the other thing is, if you make the bevel about this length, depends how cavalier you want to be, it's probably going to stay there by itself. There's enough kind of length to that tunnel and enough friction where arguably for many eyes, you don't have to tie the suture. I always do. As a second kind of opportunity to do the venting slit, as well as just additional, because I'm not securing the plate. I use that suture there. Here we see the needle going in. We see the little bubbles of the viscoelastic there. It's a pretty small pupil, so you may not see the pupil all that well. Another trick you can do if you're bad at threading the needle track, or just sometimes it's hard, is I use retinal microforceps here to basically implant it. And I find this is a nice technique to, especially if you're inferior tubes, to help with positioning. So you can do this, you just shove the little forceps, and so they're more rigid than the tube. I think I had the hardest time. I'm sure it's a resonant case here because I'm fumbling with it. So you can basically grab onto the tube, put it exactly where you want it, and you just let go, and then just hold onto the tube as you withdraw the forceps. So it's another tool you can use to get the tube in the right place. And we chose that in this case because this is a small pupil. It's going to be hard, but we can see the forceps. We put them all the way in the eye. We kind of stretch the tube a little bit, then we release and withdraw the forceps. The tube stays in place, and voila, we're done. So like I said, because we're not securing the plate, you don't have to. I've done it without a tube, just with a nice long tunnel. I think the tunnel needs to be at least 3 millimeters long, so that with enough friction and surface contact to prevent, AP migration. I always like to, and once again, part 2 is this is where I use use the needle track as a venting slip. So I take a scleral bite. Then I take that same suture and take another pass, or go back the other way, whatever. But the second pass goes through the tube to provide venting slits. And if you have the suture track through the tube, it'll help it maintain a little bit longer. So you get a slow kind of drip, 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 drip from this. But because the tube's tied off, you're not going to have that posterior flow right now. And this helps mitigate IOP spikes in the early phase. And it's remarkable. Often patients are off drops post-op day 1 and aren't back on them. And then we go through this phase, there starts to be some scarring in place, kind of BLEB encapsulation to prevent hypotony, because we don't want free flow too early back to the plate side, because you will get hypotony. And then it all kicks in about a month, just with that gauge of suture or size of suture. So you can see this looks like a 7/0 vicryl. So it's fairly big, but just make one pass. Here's a little scleral bite underneath the tube. So it's a good bite. Nothing bad's going to happen with that. This is a very safe space. If you put a suture full thickness in this area, nothing bad. The retina's not there, so nothing bad's going to happen. And then it's a little bit long, but then you make a second pass, and like I said, this can go through the tube. It can go through a little bit of the tube and go through a lot of the tube. And that pass is done, and we'll just tie this to secure this in place. And once again, you can see the tube sitting down there in the sulcus. So you just kind of cinch that down, a couple throws, and you're on your way. And the tube will not move with this size of vicryl. This tube is where you put it is where it's going to stay. It's never going to move with this kind of securing technique. So we kill two birds with one stone, both venting and securing. And you could even as well to do the total ligation at this point. But my position, I think it works a little better if you separate the two, the total ligation versus the cinching, but they can be all done in one spot. You can put the suture outside the tube to secure it, to stop flow, and then you can do the venting slits. But I like my venting slits a little anterior, and then my closure of the tube a little posterior. Patch graft, you can use anything you want. I think we largely moved away from sclera because it's really pro-inflammatory and it's cosmetically unappealing. It looks like a big white square on your eye that people can always see, and bodies don't like other people's sclera all that much. Cornea, I think, is nice to use and very cosmetically appealing. I've used a lot of pericardium. Nowadays, I tend to use amniotic membrane, like thick amniotic membrane. And I think that works well. So there's a number of materials that can be used. I like to put some steroid over the plate, once again, to just have this eye get as quiet as possible faster. Also, I find it helps you get less encapsulation if you put some Kenalog back over the plate, just injected it after plate placement. You tend to get a little bit lower IOP lowering and less inflammation. So this is using, oops, let's see. That's not a big, okay, it's coming up. So this is what the Tutoplast looks like. And then the closure is kind of all one fell swoop. So I tend to use Fibrin glue. Once again, I've been using this about 15 years as a way to eliminate suturing and increase patient comfort. Comes in two components. Usually the way it's provided is a Diplojet, where the two components come together and are squirted out together. I find that's not the good way to use it because you can get mixing in the one of the little, I guess, accessory syringes can give a lot and the other one give a little, and you can't tell visually what's going on until it doesn't stick. So I like to separate them. It tends to be more controlled. You have a working time of about 10-15 seconds. And so when you put one down, you make sure everything's where you want it. Then you put the second component, just like epoxy, and then you'll get sticking within about 15 seconds. So I like to put the patch up. This is amniotic membrane in this particular case that I folded up to make it a little bit thicker. And so just once again, you want to cover the tape. I like amniotic membrane. I just think it's less inflammatory. So I'm all about, everything I do is about minimizing inflammation. So that's in place, just resting there for a second. Now we're going to get the Fibrin glue, and we'll use it both to secure the amniotic membrane. So I think if there's anything for someone who hasn't ever used Fibrin glue, the best place to start is securing your patch graft. So like if you're uncertain, I think you still can put a suture or two in the conjunctiva to close it. But I think the first step is gaining confidence to using this. You can just use it to tack down the fibrin. You'll see once it's tacked down underneath the conjunctiva, it's not going to move. So you don't need sutures to do it. I just do it all at once. So I put some fibrin and fibrin thrombin, which is like more water-like here. Put some under the patch graft and then underneath the conjunctiva. So we're closing both layers. So and it's just kind of contact, and then the fibrinogen, which is the thicker, is what gets polymerized and makes the stickiness. So You don't want to use too much of this. You want to, because you want to have surface contact together. So you don't want a big blob kind of inhibiting that. And then you just drop it around. And then the other thing, you just press it into place. So I have my assistant usually take a Wexel and squish it. And you basically squish out excess so you get good contact of the tissues. And then you just, after about 5-10 seconds, you can see you let go and it all kind of stays in place. If it doesn't, you just reapply it and keep the closure. So this is like lagging a little bit. This one corner down here inferiorly, in this case, it's retracting a little bit, but everything's covered. And certainly, I say you don't like that, you just try to get a little bit more glue. If you don't have confidence in it, you can always just put a single interrupted. I would just use the same Vicryl if it was on the cases. If there's prior scarring, if the conjunctiva is not real stretchy, sometimes you do want to put additional suture. See here in this case, this side, the superior aspect is totally glued down. That's good. This was retracting a little bit, so we decided just to give it one more round just to help it out and just squish it a little better. So we'll just hold it into place. And once again, you just maintain contact for 10-15 seconds, and then you're pretty good to go. So that'll stay well covered. It's comfortable for the patient. It's better than having sutures on the surface, in my opinion. As long as everything covered, that's the name of the game. If there isn't, if there's extra glue, you can see down here in the corner, there's extra like blob of glue. You want to cut that away so it doesn't stick and kind of pull out. Because the glue, if you start pulling on it, you can pull the whole blob out and it won't stick. So you want to make sure once it's in place like this, it's there. That's it. No more touch. And any extra, you just want to trim away so it doesn't get stuck or become irritated. Here's once again, this is using pericardium, same technique. Place it in place. This is dehydrated pericardium, so it's easy. You say this patient has a lot of nice tenons, very stretchy conjunctiva. It's very easy to cover up the graft. And we're just doing this like while we're waiting for the assistant to get the tubes together. Okay, here it comes. So a little bit above, a little bit low. As soon as we put the second component, you'll see this patch graft start to stick into place. So that's the thrombin, the more water-like component. And then we just stick it all together. And within a few seconds, you'll start seeing strands happen and the sticking. So this, it's an off-label use of fibrin glue. It was originally developed for liver surgery to get hemostasis, but it's very effective and very well tolerated in the eye. So like here, my assistant's just squishing it, and everything stays there. So that's good. Here's one more case, same idea. I'd say this, I don't know why this graft is a little bit on the small side, but that's the way. I tend to use the amniotic membrane, so I just take the whole piece, or if you have a quadrant of cornea, that's usually how it comes. You just pop it on. You don't have to worry about trimming and adjusting the size at all. So once again, the main thing is that if this is covered, you don't want to leave anything uncovered no matter what the graft is, because that's the way, if it's well covered, the conjunctiva will heal relatively rapidly. The other nice thing about fibrin glue is if the conjunctiva is like tight from prior scarring or thin, you can see with handling, sometimes you can start to get buttonholes and have fraying of the tissue. Using the fibrin glue largely diminishes that. And so once again, you don't have to touch it, you get it into place. You don't have to stretch anything. You don't have to worry about a suture buttonholing on you. This is a case where I use the Kenalog over the plate. That's why I included this video. So I just shoot it back in with the BSS syringe. It's a blunt syringe. And that Kenalog in place, once again, it's good for the eye. It helps minimize inflammation in the early postoperative period. Secondly, it's a trick to decrease that encapsulation. So encapsulation is our friend, but it's also our enemy with this particular procedure. So like I said, we want it to be Goldilocks or just right. So you put some Kenalog back there. It tends to help with, you get a little better IOP lowering, also a much quieter eye, much quicker. And then part two, we'll put the glue on here someday. Here it comes. And there's the thrombin, the more water-like component. And that's a little bit above, a little bit below. As soon as we put the fibrinogen in, we'll get that graft to start sticking in here. Also, this is Tutoplast, so it does soften up the mortars in water. I just usually take it out dry. Some people wet it to begin with. So here's the fibrin. Now the clock's ticking. We have about 10 seconds, 15 seconds to get this all covered. before everything starts to stick. So we want to kind of pull it up, get it well covered, get that posterior edge back, and get it covered up. So our clock is almost done here. And then once again, simple pushing down on the surface. You can see the strands starting to develop. Usually, looks like blood a little bit just because there's usually blood around. And you can see now that was kind of tight and kind of retracting. Now it's stuck into place and we can go home. So post-operatively, I typically give it a drop of atropine in the operating room, and that's it. It has a long duration of action. I use antibiotic for a week, and then a steroid. I tend to use difluprednate for like a week, a month, and just kind of taper it down. And usually once we see what their IOP is in the office, we start taking away their glaucoma medication. So I'm very patient with the steroid. They'll need the antibiotic for a week. Atropine is usually just to prevent if there is a little low pressure. We don't want them to get choroidals. And it'll wear off in about a week or so. And then just taper off the steroids very slowly. I tend to be patient, typically about 6 weeks to get them off the steroids. I like to keep them on once a day for an extended period of time. If you do that, then the eyes look very nice. And this is an eye that's a young African-American male. I thought this, Molteno was the best option for him. He wasn't going to do well with trabeculectomy or MIGS or anything like that. And this is post-op. I mean, this is the best thing is when the residents look at these eyes and you can't see it because the tube is right there at like 10 o'clock. You can see it kind of peeking the sulcus. Otherwise, it's healed up very kind of cleanly and nicely. And a patient who's really tends to scar, he's from Africa. Once again, we get a hint. You see the tube in the sulcus here. The post-operative area, well healed. It's about 2 months out post-op. So the eye looks pretty happy and good, and we can see the tubes in good position working.
Dr. Noecker, hey, it's Joe. We have a question that's actually been typed in. It's from Dr. Okiki. Okay. Do you use Kenalog routinely? If not, what is the criteria for choosing? And do you ever use MMC over the plate?
That's a good question. So I do. I mean, usually it's remembering actually to do it during the case is probably the biggest obstacle. But I think with the Molteno3, I think it's a big advantage. And to be fair, I think it's, especially if I do an Ahmed, I use the same thing there as well. I think you have to be a little careful with Barvelts. We have had some like too low a pressure with a Barvelt. So it does work to decrease the capsule thickness. But once again, I think with the Molteno3, it's a great thing to do. And I, knock on wood, I haven't gotten any prolonged hypotony. With the Barvelt, it's big. And if you don't get a capsule formation, you get hypotony. So I do. So it's usually like 0.2 cc's of Kenalog or something like that. And once again, I think it's good for get a sustained release early in the game, but I think it also plays a role in encapsulation. In terms of the mitomycin C, when you look at how mitomycin works, and because with these plates, it's much more of a foreign body reaction. And so, mitomycin C, I use a lot in my other glaucoma procedures, my filtering procedures. But when you look at the type of reaction that happens in these plates, once again, go back to that slide, looking at the smoothness of the surface. It's a foreign body reaction. And once you have collagen laid down, mitomycin C does nothing to attack that collagen. It gets the fibroblasts. So the idea with mitomycin is that you're preventing, fibrosis. You don't want it to happen at all. Once the collagen's laid down or the capsule's laid down, you're not going to thin it out really anything significantly. So it's been looked at. I've tried it. I tried everything. But we just found it didn't make a difference personally, and the literature kind of supports that. But I think Kenalog actually works really well. Okay, so I think we covered all these points. This technique, like I said, I've been doing it. I have 15 years of doing this. I think the subtle tricks are using venting slits. I think that's a key, and there's some variations how to do that. I just kind of do it the same way every time, and that works for me. I get good efficacy similar to that with a Barvelt. I don't really use Barvelts very much anymore, rarely. I think the pressure ridge really helps with that kind of transitional phase. So you don't get the big boom in IOP when that suture opens up. And with the fibrin glue technique, I think it helps, with the efficiency of the surgery, but also provides kind of good patient comfort and cosmesis. And that's all I have. Here's my email if you have any follow-up questions. And certainly we can open up for other questions now if you'd like.
We have actually a few that are people are posting them. I'll try and catch up on some of them
Okay.
and give you. Okay, so a secondary question to the first one from Dr. Okiki was, how much Kenalog do you use? And I've tried using Fibrin closure and had a number of wound dehiscence that required post procedures. Any suggestions to help? Do you use BCLs?
Yeah, so those are all good questions. So, you know, so I think you have to look at what the risk is. And so we've done a couple abstracts on this, you know, what the risk factor for exposure is. So we find that number one, inferior tube placement, I don't use exclusively. So if it's down below, I don't use it exclusively fibrin glue. I'll put a little suture to help. I'll fibrin glue the patch, but I'll still do the conjunctiva. Number two, I think once again, make sure you're separating the two components so you really know their stick. Like some of these cases, I mean, this is just a few, but you know, in the videos, but I really like pull the conjunctiva really forward, like a few millimeters onto the cornea, and make sure that it's sticking well. Because if you have like nice tenons and cornea, you can kind of lay it in, and a lot of eyes it looks okay, but it's if the components aren't mixed well in kind of a nice smooth monolayer, you'll find it moves post-op. And I think if there's any doubt, you always can put a suture. So even if you like one side stuck great, maybe the other side still does need a suture. Like I said, the patch graft, I don't find. If it's moved from the patch graft, then I really worry that the application wasn't that great. And then lastly, I worry about prior scarring eyes. I think we didn't really delve into this, but you know, an eye that's had a prior trabeculectomy, there's mitomycin C around, and I think the fibrin glue will certainly help mitigate any early leakage, I guess, around the tube and any early hypotony, but it does go away after, you know, probably a week or so in most cases. And so those prior mitomycin eyes are very high risk eyes as well. And the other thing that I do is I always make sure the tube entry site is fairly posterior. So even if there's a little movement, you know, it's still back 2 or 3 millimeters and helping you there. So a little bit's just, you know, a little bit of judgment, but avoiding like prior scarred eye. I wouldn't go for the gusto. I think you can tack down my position. I don't see a reason why you can't not ever use it to do the patch graft. I think the conjunctival retraction, that's a little bit different animal, and some eyes will do fine. I find most eyes will do fine, but they have a lot of prior scarring. Those we found. So we saw inferior tube placement, prior scarring, the two biggest risk factors for kind of going, you know, naked with just a glue and being at risk for retraction. So I think if you avoid those things, and a little bit of practice too, like I practice a lot of cases just tacking down the patch graft, and you know, I put a little bit back even posterior to help the plate not wiggle early on too.
All right, we have one more question that's written, then we'll turn it over. Actually, we have two now. We can turn these verbal if anybody wants to, but I'll read you the ones that we have right now. Okay. Do you ever, it's right in between. Bear with me. Do you ever deepen the sulcus with viscoelastic prior to tube insertion? If so, do you remove it?
Nope. So like I said, I tend to use Helon for these, and part of it, so the answer is I leave it, and I didn't address that in these videos, but I leave it behind because my position is there's nothing worse than hypotony. So I'd rather the patient come out a little high on the first day, which weirdly enough really doesn't happen all that much when you use this technique, because I think you do get a little bit of leakage. So I leave the viscoelastic behind. So the first steps of the cases, which we didn't dwell on today, is my very first step is I make a paracentesis. I tend to block. These are the one cases. These and micropulse are the two cases types of cases I block still. So they have a block, but I also put a little extra lidocaine inside the eye, just like I started cataract. So paracentesis, I make an inferior paracentesis, so that I put the syringe across the anterior chamber into the sulcus, if that's where we're going, or into the angle, if that's where we're going. Blow it up at the beginning of the case to firm up the eye, and that way the eye is firm and has a tendency not to collapse, especially a prior vitrectomized eye or something like that. Then at the time we're about to do the surgery, we see if that stayed there. If it didn't, then I'll reinflate the sulcus a little bit more right prior to insertion. But I think that's a key thing. It makes it easy. once again, there's nothing worse than traumatizing the iris or something and they get blood. Because this, you can see these should be relatively blood-free cases. It's just something that's, unnecessary. It's not the end of the world, but it's unnecessary. So I do. So I put it very first thing in the case. I just make my routine very similar to even what we do for cataract surgery. So paracentesis, a little bit of lidocaine, viscoelastic into the sulcus if that's where we're going, or the angle if that's where we're going. I think it helps keep the eye kind of firm. If the pressure is really high, it's also the opportunity to deflate the eye a little bit. If pressure is 60, that paracentesis, all right, at least even with the viscoelastic during the case, is probably more like 20 during the case. So I think it's a way to mitigate that right away. And I think it helps with the working space. Then I leave it behind. I don't like the eye hard, but I like viscoelastic in it. And I find when you do that, the rate of, collapsed chambers and stuff really goes down dramatically. It just makes the post-op care much better. And if it's a little high, you can always take it out, with the flipping the paracentesis is there. If we do need to put more in, or take it out, it's already there and it makes access a lot easier. That's just what I do.
All right, got a few more here, then we'll open it up and see if anybody has any verbal questions. How often do you see anterior migration of the tube without suturing it? And do you have any experience with the non-valved OMED clear path? If so, how does it compare to the Molteno?
All right, so those are good questions. And so there's two different things. So one, what was the exact question? How much does it move without suturing?
Do you see anterior migration of the tube without suturing it?
Rarely. But my position is that even one case kind of sucks, to be honest with you. So, the worst thing is it backs out of the eye and then it doesn't work at all to lower eye pressure. So that's what you worry. So part of the answer is it depends on the eye. So we have average eyes, and then we have glaucoma weirdo eyes. And those weird eyes, if it's a short eye, just for the patient moving around, I find that the tube can end up longer in the eye just because there's less kind of free moment. I think in an average eye, if you make a 3 to 4 millimeter tunnel, if you make a long tunnel, it's very unlikely to move. But because I'm doing the venting slits there anyway, I've just come to think I'd like my incidence of that long tube in the anterior chamber to be close to 0. And probably get a long tube like once a year. And I have no idea why it happens, but that's glaucoma surgery. So my position is, most of the time you don't have to. And if the tunnel is long enough and the plate is posterior to the equator, that equator is going to hold it back. So it's going to make it hard for it to go into the eye. The other trick with the glaucoma surgery is, and you can see in my videos, I don't use a traction suture, but the other risk is when you use a traction suture, I find it confuses the anatomy, and sometimes you can easily lose track of where you are. So that's why I've developed it not doing a traction suture. I think it makes the anatomy a little truer, because you get fooled. You're working with the eye turned down, and then at the end of the case, it kind of turns back straight and things aren't exactly where you thought they were. So it just decreases the incidence. I say 90% of the time in average kind of shaped eyes, it's not big, but a really big eye or a really small eye or eye with scarring, and you just know when you're in there. Sometimes the lid speculums, on the tight side, you just kind of know those cases where they're a little abnormal. And I think it's just insurance is really what it is. So it can be done without it. And most of the time you'll be just fine. But I do it because I just don't like dealing with things post-operatively.
Okay, so the second part is the comparison versus the clear path, the non-valve OMED.
Yeah, so I have experience with the clear path. I put a dozen or so in. And the thing with the clear path is like, you can kind of see the way I do my surgery. It's kind of like does nothing to help my technique, because the position holes are really anterior. I find in my hands is that I have a higher rate of hypotony with the clear path. And so, it's kind of based on an older model of doing it. I used to use, the stent, to kind of keep it in there. We found that we could just secure the tube just as well with just a external vicryl. Has kind of a pathway and I think it may be that kind of little neck of the clear path, which kind of just have more filtration anteriorly where it's less easy to encapsulate the entire plate is my guess, because the plate's, it's weird shaped. It's, the posterior aspect, and then you have that kind of little neck going anteriorly. And the idea is that position holes are more anterior to make suturing easier. But I think that's a source because I have about a 50% hypotony rate, which is, once again, a little bit unusual for, with the Molteno, you almost never get it. So I think there's a role for everything. I think, a lot of these things are very similar. But in my hands, I've had about a 50% hypotony rate for a while, and then, we can do things to get rid of it. That's my experience.
All right, one more written question. Do you ever do more than one venting slit? Oh, actually, I'm sorry. There's two more. Another one just popped in. Doesn't the glue negate the function of the venting slit?
No, it's not. So, so this is a glue. It's not a sealant. So, the one sealant we have, so glues kind of adhere surfaces together, and, the glue like we have, like with the Assure, which is approved for use with cataract surgery incisions, that's a sealant. That will stop flow. The Fibrin glue will do it a little bit, but the water will kind of push, moving flow will push that water push that away. So if you see, and you can see that if you have a lot of leakage and you say at the end of the case, we want to put a whole bunch of BSS in the anterior chamber and just really blow the pressure, and there's a hole there, it'll push that Fibrin glue away, because that Fibrin glue is kind of a gel, and it's still externally sticky, but it's not that firmly in place. So merely the pressure of the water, the aqueous coming through that tube and forming a droplet will go in that space, and it doesn't seal it watertight. So that's one thing with Fibrin glue. It's not a watertight seal because it doesn't take that much water to kind of push it off the surface. It'll hold things generally in place, dry tissue. So that's the difference. Like versus Assure, you use that to I use that as a stop a leak. So if I have a leak in the sclera, I pull the tube out, I often use Assure to plug up the old tube hole because it's sometimes hard to suture those back closed. And that works great for stopping a leak. And that'll stick around if it's protected for a good week or so, especially under a contact lens. But the Fibrin glue, it doesn't make it watertight. So you have to kind of understand that to, what we're going to use in what situation.
All right, one more. Do you ever do more than one venting slit depending on the pre-op IOP?
I don't, just because I like to keep it simple. And I think, I try not to do hocus pocus and say that I'm that good that I can titrate IOP or flow by venting slits. It's a little unclear how venting slits even work, but they seem to work. And let's see, I use a pretty big needle. So the answer is no. I just usually go with what we know, and that usually for whatever reason. And if we look at it, it makes sense. I mean, you have one hole. It's kind of like the same concept with any of like the InFocus device or the Zen or whatever. It's like you pretty much know the size of the hole you made and flow is going to happen. And I don't really want you don't want a lot of flow. You just want to kind of keep it from spiking to 40. So, if it's at 20, I like eye pressures in the teens or around 20 coming out of the gate. I mean, that's very safe and the eye doesn't collapse, etc. So once again, I err on the side of not having hypotony. I don't want a big spike, but I don't like low pressures. That's when choroidals and things happen.
All right, so that's all the written questions. Oh, there's a few more. Just as I was about to open it up to the audience, just if anybody actually has a question they would like to ask, also on the bottom, if you take your cursor to the bottom left hand, there will be a mute button and you can unmute and you can come off, but I'll read you the next question. To be clear, the Vicryl was passing through the tube?
You can do it either way, but that's the technique you just saw. So there's one, and you can vary that. You can just use it purely to cinch the tube. If you don't want to do, you can, you don't want to make a venting slip, don't. And I've done it both ways, especially in like leaky situations. Like I said, these pre-MMC scleras where it's just not so good. But yes, so that pass, it does two things. It secures the tube. It's not going to move AP forward or backwards. Number two, you have a hole there and the sutures through that. So it's kind of helping wick the aqueous. And if you want to study it under the microscope, you can watch it. You can watch it happen. You can watch the aqueous kind of track out that suture.
Hang on for 1 second. Also, yes, Dr. OKK, we can get you the the copy of the video. This will be this. So for anybody that came in late, just so everybody understands.
It'll cost Dr. Okeke extra.
For anybody that came in late from a timing standpoint, this was recorded and we will have this available to you. If anybody would like to ask any questions at this point, please unmute, and it's an open forum at this point.
I think they're mesmerized, Joe.
They're absolutely mesmerized. It was fantastic, Dr. Noecker. Thank you very much.
Does anybody have any other questions before we go? Like I said, just shoot me an email. My email was up there. noeckerrj@gmail. If anything comes to your mind, or that's it. Thank
All right,
you.
well, thank you very much, Dr. Noecker. Go ahead, Kate.
Thank you very much, Dr. Noecker. Really appreciate it.
It's always a pleasure, Kate. Good
Thank
day.
you.
Good
Have a
day.
great evening. Good day. Good day, mate.
Too much fun.
Thank you.